and thank you for joining this first Global Thrombosis Seminar series from INVENT, the network of network. And the topic of the day is building patient engagement in clinical VTE research. Next. So in case some of you are not a member of our network, so the INVENT-VTE network is a partnership of 10 national VTE research networks gathering over 450 investigators around the world. And what we're trying to achieve together is to support each other and promote collaboration to produce relevant, high-quality academic VTE research. Next. So these are the members of INVENT, and I'm sure that most of you are part of one of these national networks. Actually, we always try to expand the collaboration as well. So if you know of other countries that might be interested in joining, don't hesitate to extend the invite. But these are the current members of INVENT. So this seminar series is actually a new initiative from your network. And what we wanted to achieve was to feature some inspiring and impactful international thrombosis research initiatives, collaboration and efforts across the network, and doing a mix of some update or research in progress type of talks, along with some very original or innovative research concepts or tips related to the VTE research efforts worldwide, highlighting what our network countries do very well. And I want to especially thank Sanofi for sponsoring this seminar through an unrestricted educational grant, meaning that they had no say in the choice of the topic, the speakers, the content of the slides, or anything like that, but were very kind to help us initiate this effort and promote it. And next slide. Yeah, and so today's presentation is about building patient engagement in clinical VTE research. And what we want to achieve is to recognize good practices in integrating patient engagement in thrombosis research, describe the value of working with patient partners in thrombosis research, and identify strategies to improve the experience of patients and researchers working together. And we're very, very fortunate to have two teams of a couple of investigators with patient partners who have been doing that with tremendous success for the past few years. And I'm really excited to listen what advice they have for us and how to improve our practices in the topic. Next. So during the talks, don't hesitate to send your question in the chat. We will leave the question and answer for the end, after the end of the two presentations. But again, don't hesitate to send questions our ways. And without further ado, I will let the mic to the first speakers of the day, Lisa Duffett and Carol West, from the CanVECTOR, so the Canadian network of INVENT. Carol and Lisa.
Thank you, Dr. Legal, and thanks very much to the network for the opportunity to do this, and especially for us to share the platform with our Irish colleagues. The benefit of a virtual meeting like this is that I think we attract more people. The downside of a virtual network and not being able to meet in person is that we're not able to go and share a couple of Guinnesses after the presentation. So again, we're looking forward to hearing from our Irish colleagues, and we hope you're looking forward to hearing from all of us. And I should have said good morning, good afternoon, and good evening, because I understand that there are some participants on this call who are from a part of the world that is just wrapping up its day, unlike us, for whom the day is just beginning. The next slide, please. Now, Gregoire has just put the objectives of this session before you, and just a couple of words from our side about what it is. Learning objectives, and that's the context in which these objectives were developed, are always a challenge. They really represent what we hope you can take away from this morning's presentation. So we hope this is of value to you. And we had to think about these and think about what we wanted to say in terms of the objectives. But We hope that these, which Gregor has read out, will be takeaways for you, so that you will take away some good practices that you weren't aware of, that you will be able to better understand and describe the value of working with patient partners and take that back to your own research projects. And we also hope you can identify strategies that will improve the experience. We're always about continuous improvement in terms of the relationship between investigators and researchers and patients. And again, we hope that you'll feel the same, that you've left with some good practices today, but also left thinking about strategies to improve the collaboration between researchers and patient partners. So over to you, Lisa.
Thanks, Carol. So I just wanted to begin with just a little discussion about why it is that researchers should be thinking about and considering partnering with patients on research. So I think we all know that a successful research team already partners with various experts. You might have methodologists, statisticians, knowledge translation experts. And I want to get across the message that a person with lived experience in the disease area is another essential expert that is able to add to this list of your team that can really strengthen and round out your leadership team on a research project. So researchers have lots to gain from working with patient partners. I think some of the direct benefits that I've seen in my experience is making sure that the research team is, first of all, asking the right research question. Is this a priority that patients and their clinicians need to hear about or learn about, and the outcomes are useful? You want to make sure that you're measuring outcomes that are also meaningful to patients and that are what they feel is important and would change their decisions about their care. The patient partners can help you with designing your trials that reduce the burden to participations, understanding what these patients are kind of going through already in their lives and a new diagnosis, and making sure that the clinical trial is not so burdensome that participants will choose not to go forward with it. Trial information and consent forms can often get very confusing and detailed, and our patient partners have given us a lot of experience and insight into how to make these understandable, and that also goes back to reducing barriers and increasing the people who are willing to be part of research in the first place. And finally, patient partners have a lot to contribute in the areas of knowledge translation. We often focus that on getting the message out to more healthcare leadership and physician groups, but patients also need to know the results of clinical trials and how those results might guide their decisions that they make with their healthcare team. And ultimately, all of this together, we hope that would lead to better enrollment in our clinical trials, improved translation into our research, and most importantly, improving the health outcomes to our patients by building research that is strengthened by our engagement.
Now, the other side of this conversation is why patients should become partners in research. And I often say no one wants to be a patient partner. In fact, the eligibility criteria are hard-earned if you're a patient partner. As a patient partner, you had something go wrong with your health. As a caregiver, someone close to you had something go wrong with their health. It's not a great starting point in terms of patient partnership. The CanVECTOR Patient Partner Council includes people with different lived experience who have different reasons for wanting to become a partner in research. We're a diverse group in some ways. Our group includes parents with young children as well as grandparents, and there's really quite varied experience with VTE. But we're pretty homogenous from a gender and socioeconomic perspective. So we have some work to do on diversity ourselves. Nevertheless, everyone has agreed to make time in their busy lives to become a partner in research. Now, the need for knowledge is a big part of this. Blood clots are mysterious. Diagnosis and therapy may be uncertain and generate many questions. And again, that uncertainty generates fear. Quality of life issues can be unknown. So we want to learn things as patient partners. But we also, and this is a really important point, we also want to share things, our experiences, good and bad, that may impact research designs and questions, And our belief that our contribution as a patient partner in research will in fact help other patients and not only ourselves and our own conditions. That last part is at the heart of why people volunteer at all, to make a difference. As you'll see throughout this presentation, CanVECTOR has created conditions in which we can make a difference, working as patient partners in research. And in a way, and as you'll see, we've really only just begun.
So how did we all begin? CanVECTOR grew from a previous group, which was predominantly a researcher group, which already had a fairly long history of working together and collaborating on clinical trials. In around 2014, there was a desire to expand the scope of this group, and then a grant opportunity arose from the Canadian funder, CIHR. And with that, the CanVECTOR network was born. So in addition to bringing patient partners to the table, the CanVECTOR network also started engagement with research support staff, trainees and early career investigators, translational and basic science researchers, and knowledge translation networks. So altogether, this rounded the CanVECTOR network into a comprehensive research network. Within Canada, we had already had a very strong group called Thrombosis Canada, who has an education and advocacy mandate. And they too also partner with patient partners. So by intentional design, that we decided to focus our CanVECTOR network and the patient partner activities on engagement in the research process itself. So what's really important to know about our group is that our patient partners were with us from the beginning. They were part of the design and the initial funding granting applications of our structure. And the CanVECTOR patient partners are integrated into the governance structure of our network. We have always a minimum of 2 patient partners who sit on the scientific steering committee and are part of important decisions for our network. And we also have patients on our external advisory committee to give us feedback and advice. Our network is divided into 6 platforms, which each focus on areas that CanVECTOR is involved in. And our patient partners have interactions and relationships with many of those platforms. In particular, part of working groups and major projects with the clinical trials platform, the knowledge translation platform, and the basic science platform. And then finally, the Patient Partner Council, which is our collection of patient partners that work together, form a 6th platform. And that's where we really focus on the patient engagement planning itself and how our program is structured and operated.
Now, before I speak a little bit more about the Patient Partner Council, I want to recognize the vision and commitment of CanVECTOR leadership for not only setting up the institutional structure, as Lisa's described, of the Patient Partner Platform, but also for providing constant encouragement and support to patient partners as the CanVECTOR network itself has evolved. So special thanks to the efforts of co-directors, Dr. Susan Kahn and Dr. Mark Roger, and to our own Dr. Lisa Duffett. And this is the first year that we have a patient partner as co-lead of the council, and that's a big step forward, and it certainly wouldn't have happened without their full support. We have 8 to 10 current patient partners, and we're intending to recruit several more. It isn't only the lived experience with VTE that's important in the selection of patient partners for research. It's personal qualities such as an interest in positive change, time to give, good listening skills, respect for each other's views, even when they don't match our own beliefs, ability to give helpful feedback, and ability to work well with others. And these qualities are part of our recruitment package so that people can see exactly what we're looking for in terms of, again, not only the lived experience, but also the qualities that a person who's a patient partner can bring to the table. And our recruitment process involves an expression of interest written by the patient as well as an interview. Information about our process is documented and available. We have monthly meetings with flexibility as to when those occur. For example, to accommodate patient partners who are teachers, we've scheduled meetings at the end of their day. We have inclusive and shared decision-making on items like compensation. And for the past several years, we've collaborated on sessions for the CanVECTOR National Conference, including a video made by one of our patient partners, which is a good introduction to us and what we do and is available online. Our work on orientation and training is a work in progress, and we're very committed to provide support to all our patient partners. We have written guidance and provided sample letters of support for grant applications, and Lisa will talk a little bit more about this later. We've endorsed the good practice of two patient partners working on projects together and strive to do this, again, as Lisa has mentioned. And we've also referred patient partners to outside training and resources, which can be very helpful.
So when I put together a slide like this, that's always a great reminder of all of the things that our patient partner council and patient partners we've worked with have accomplished. And I'm pleased to list off some of those things. So as I mentioned already, the patient partners are playing a very active role and a large commitment to our network leadership team and oversight. They sit on the scientific steering committee and part of all the decisions and reviewing the policies that the network makes. We've also to date had patient partners integrated in more than 30 clinical trials. Many of these patient partners have actually been part of these research groups right from the inception of the research idea through grant and multiple grant submissions and revisions. And the patient partners will write letters of support for the grants that they're involved with and are sometimes listed as either a co-applicant or a collaborator on those efforts. We've also recently been venturing with collaborations with our basic scientists in our network, and I'm quite excited to see how that level of engagement on a different aspect of research will be in the future. CanVECTOR does have some internal funding opportunities, and we include our patient partners as reviewers in all of these applications. In order to do this, we had to design a patient partner specific review form, give some guidance with the feedback of patient partners who had experience in this area to really allow the patient partners to raise and provide written feedback on applications from a patient-oriented perspective. Right now, our Patient Partner Council is leading a project about research priority setting, which is very exciting. We're partnering with the James Lynn Alliance, and this is a process where we gather patients, but also caregivers and clinicians together to identify what their top unanswered research questions are and where our future research should be focused to address these most important questions. Carol?
One of the most exciting things that we're involved with at the moment is the VTE cause study, which aims to standardize core outcomes measured in research. There's a couple of things that are really exciting about this for patients. A core outcome is an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. So again, we're working with INVENT and international partners to establish core outcomes in VTE. Again, a very exciting prospect for patients who are really at the center of this research. It also heavily engages clinicians and other key stakeholders, and two of our patient partners are on the leadership team for this project, and one patient partner has been named as principal investigator for a grant to support the project. And this is a first for CanVECTOR. So once again, congratulations for the support and leadership in terms of that. One of the other really important areas of work that I love and I've been involved with since my initial engagement as a patient partner is in knowledge translation. We have CLOT+, which is a mechanism by which research articles are reviewed and rated by patients and clinicians, and those with the highest quality and impact are highlighted. So a selection of these are translated, and really rather than translated, I think they're transformed into patient lay summaries. Patient partners are part of the team that does this, and it can be something as simple as highlighting an acronym and saying, we really don't know what that means, and let's include that in a glossary. That's another thing that CanVECTOR does very well in terms of supporting patients and even beyond the patient partners. Again, a very important part of the work that we do, ongoing, hands-on, and satisfying for patient partners. The other thing that we're stepping into is what we would call patient partner leaders or patient partner leadership. So our group aims not only to improve, back to our goals today, and strengthen our own program, but to become leaders in the broader field of patient engagement in research. We've developed important procedures and guidance. We try to document those as best we can. We have terms of reference, we have compensation policies, we have guides for patient partners, we have recruitment criteria. So we aim to publish and to share that information and that experience. And we've already played a supportive role in helping some Canadian investigators outside VTE also engage with patient partners. Again, another very important part of what we do. And as I said earlier, this is an area in which we're only beginning that kind of outreach and development of expertise.
So one of the most important strategies for success of our program has been an open communication and feedback from both our patient partner group, but also the research team that collaborates and works alongside them. There's no one-size-fits-all approach to patient engagement. And I think one of the single most important strategy for success that we've learned is actually to co-build our program and our policies and procedures with our patient partner group and our researchers so that we're all in this together as a team effort. So we'd like to finish our presentation by just sharing some of the key insights and lessons that we've learned in this process. Carol?
So what do you want me to do? What do you want patient partners to do? I was left with this phrase several years ago, again, as a very new patient partner. I was doing a master class in the days when we could actually gather in person. And a caregiver struck me. She was a young mother with a child who had a rare disease. She had a young family. She obviously had a lot of obligations, but she felt it was incredibly important for her to participate as a patient partner in the health area that affected her child. And her point that she kept repeating over and over and over again was the need for guidance, certainty, understanding on her part of what it is that researchers expected her to do. Her time was precious. And again, the researchers in that area were so fortunate to have her expertise as a caregiver. And what I would say is that goodwill is important. And we all have goodwill as patient partners, but it's not enough to create conditions for success. So back to the what do you want me to do, without an understanding of specific contributions a patient partner can make, patient partners may be confused. I mean, they may feel they don't have enough knowledge, they may feel they have too much knowledge, they may be easily frustrated. And this is where some qualities like confidence and optimism and other things come in, but they're not there on day one, and they really need time to develop within the research milieu. So that's why the question, what do you want me to do, is so important. So patients, caregivers, and families want and need to be meaningfully engaged at all stages of research and can be extremely valuable contributors when given appropriate opportunities and support. So what does that support look like? Is there mentoring? Is there compensation? Are there other health or social supports to facilitate our engagement? And I will say CanVECTOR pays attention to all those things, all those details, and all those mechanisms of support. We need to understand research goals, priorities, and timelines. The earlier we're involved in research processes, the better. We need glossaries to help us understand research terms, all the acronyms, and even commonly used terms like major bleeding that's often reflected in research summaries. And again, CanVECTOR has done excellent work in this area to develop glossaries. So we need an opportunity to contribute and to be heard. And that can happen in an unstructured way. But an excellent example of what can be done comes from a project I'm currently involved with. Every meeting has a standing agenda item for patient partner input. I see this not only as an invitation to contribute, but as validation of patient partner contribution. It makes my day every time I see it. So keep communication lines open and tell us what you want us to do.
So one of the lessons that we've learned from our feedback with our patient partner group is, as Carla suggested, defining roles and expectations. And a way to accomplish this is actually having a written terms of reference. So talk to the patient partner at the beginning. What are the ways that the patient partner fits into the research team? And this could be variable depending on what your research team is and what phase you're in. You can imagine that if a research team is just gathering for the first time and trying to really define the research question, the protocol, there might be more opportunities for a patient partner input into that process than when a patient partner is joining a trial that might already be recruiting. And that's okay, but that needs to be discussed up front. The patients know that when they get into this conversation, this is where the opportunities are on the conduct of the trial, or maybe the knowledge translation, and making sure that they're agreeable to joining the project in that type of phase. We found it to be very successful and respectful to have this written down. And it's a document that's jointly written with the patient partners and the research team following a templated form that just explicitly states what the expectations are so we can maintain a respectful relationship going forward. I think it's always important to acknowledge the time commitments, but also how long the project might span for. And if the patient partner has an ability to commit for that time span, and how the time and hours of commitment might change over a multiple year project. We introduced compensation to our network about 18 months ago, and this has been an important initiative for us. This is a volunteer patient partner group, and the civil compensation is really thought of as an honorarium or a thank you for the gratitude. And I think it's an important acknowledgement of the respect and value that we have for our patients' contributions. I think Carol has already spoken to the importance of communications. And I always like to remind our researchers that there's a lot of things in the research process that aren't necessarily as obvious to a patient partner who's coming in for the first time. For example, I know it can be a 3 or 4 month lag from submitting a grant to getting a funding decision, but it wasn't always communicated to the patient partners at the beginning. And that was frustrating because they felt, okay, we had daily emails for a week there, and now it's been several months and they haven't heard anything. So just reminders to the research team to really make it clear when communications would be expected, and sometimes sending emails that might just include there are no updates so that the patient partner continues to be involved. And then lastly, remember acknowledging your patient partners. This could be acknowledging them on grant applications or on publications or in the work. The patient partners are doing an important contribution, and it's important to make sure that they're acknowledged. It's also important to make sure that they understand the meaning of those acknowledgements, because terms like principal investigator, co-applicant versus collaborator are kind of familiar to the research world, but not necessarily to the patient partner world. And so if they're agreeing to be acknowledged, you need to understand what that means and be accepting of that.
Now, we're not suggesting that we have anything in common with Mother Teresa. I'm not sure about our Irish colleagues, but I think Lisa and I can probably say that we don't have a lot in common with Mother Teresa, but we have this in common with Mother Teresa. And this is what she said: I can do things you cannot, you can do things I cannot, together we can do great things. And in the context of patient partnership, this is perfect. We know things you don't, you know things we don't, and together we can do great things. Thank you.
Thank you. That was great. Thank you very much. So don't hesitate to send questions to Lisa and Carol through the chat, and I will let the microphone to our next set of speakers. So Fionnuala and Ainle and Anne-Marie O'Neill from the Irish network, and again on this patient engagement into research. Thank you very much for being here, and I will let you the floor.
Thank you, Gregor. Oh, what a fantastic presentation. That was really excellent, Carol and Lisa, and I've learned so much. And I agree with you, absolutely. Together we are stronger. You know, if we align ourselves together, we'll move mountains. It's an absolute pleasure to be involved and to present our work and our collaborative work. Thank you so much for the invitation to share. I agree, as patients, as a rule, we want to be involved in the process of finding answers and we find it very positive experience. We really want to help. We want to make a difference. As Lisa and Carol have said, we definitely want to make a difference. So this morning we're going to speak about the patient voice, the Irish Network for VTE Research, and the journey to VTE awareness in Ireland. Our journey has been a little bit more organic, I think. We've kind of just collaborated and joined together over the years and created what we've created organically more than in a structured way. But it's really interesting to learn how to install those structures and maybe improve what we do. So thank you, girls, for sharing that. So the patient voice, what we're really about is Thrombosis Ireland are the voice of the people who survived. Here we've got Amy, who survived a CVST, or Rachel, who survived after having COVID and getting a VTE, or we've got Paddy, who had a sports injury and got a DVT, or Sarah, who got a VTE during pregnancy. And they've all contacted us for support and information, and would really like to be involved in finding out the whys, the wheres, the whens, and how we can improve things, or you know, the whole scientific research area they're really interested in. And they're what they drive me, and they drive our organisation to work with the like of Professor Fionnuala, Ainle, and all the teams in the different universities to research as best we can. But the real people that are, you know, give us that strength to really look for answers will be those that didn't make it, the young lives that, you know, potentially preventable deaths that have happened over the last few years that we really want to prevent ever happening again. And with Niall's parents' permission, I'm going to tell you a little bit about his story. He's 23 years of age. He hurt his leg in work with a fall and was getting a camera procedure on his knee. He did have a pre-op assessment, but there was no mention of the risk of blood clots or the signs and symptoms that he should look out for after the procedure when he left hospital. And when his mom picked him up after the 2-hour procedure, he was in an elastic bandage and on crutches. But as the days went on, his leg swelled and was very painful, but he didn't do anything about it because he hadn't been warned, so he didn't know any different. He thought it was from the procedure, and he had an appointment to go back to his specialist in 10 days. And after about 6 days, he says to his mom, I feel well enough to go back to college. And his mom dropped him off in the next city down from where he lived to college. But when she got home, a few hours later, she got a call from the college to say Niall unfortunately had collapsed and was on his way to hospital in an ambulance. But by the time she got to the hospital, Niall had sadly passed away. It just felt like such an unnecessary death, and the family are just racked with guilt because they feel maybe they could have done more or they should have known more. And they're also angry and just distraught and don't want it to happen to anybody else. So they contact us and they say, use Niall's story, let us know what we can do. And then we've got Eve here, and it's a more recent story, has been all over our media at the moment because it was just in the coroner's court. But Eve is 21 years of age, and she was on the pill. She fell and hurt her leg. Her ankle was very swollen, and she had an idea that it could possibly be a blood clot, but nobody really listened. She made her way to A&E and mentioned it to the healthcare professionals, but they didn't seem to listen or believe that she could be right. She had lots of tests to see had she broken her leg, but no risk assessment for VTE. 4 hours after she was discharged from hospital, having been wheeled to the door of the hospital by a porter because she couldn't actually walk, she was in so much pain. Unfortunately, she had a massive coronary heart attack as a result of blood clots in her lungs. And her family actually only wrote to us yesterday to say, please use her story, raise awareness, both in our young girls who are taking the oral contraceptive pill and for anybody with a lower limb injury. We really need to raise awareness in our community. So with their permission, I shared this story today. Next slide. So for that reason, I suppose that's what drove us to set up the Irish Network for VTE Research. And I'm going to hand you over to my lovely colleague, Professor Fionnuala. Thank you, Fionnuala.
Thank you so much, Anne-Marie, for sharing Niall's and Eve's stories so beautifully, so eloquently and so sensitively. It's a real honour to present with you today and to follow our Canadian colleagues who I agree did a phenomenal job. The Irish Network for VTE Research addresses an Irish healthcare priority through participation in high-quality VTE-related research with our patient partners. Because INVITE is a partnership between multidisciplinary colleagues and patients, and you've heard how this grew up naturally from the very beginning. Our 13 partner hospitals represent all Irish hospital groups and 5 Irish universities. And as Anne-Marie explained, INVITE was conceived through discussions between patients and clinicians in 2017. And multidisciplinary VTE colleagues working very closely with Thrombosis Ireland. The vision and mission of the INVITE network is to reduce VTE-related death and disability. As Anne-Marie has elegantly discussed, we aim to achieve this through partnership by prioritising research that addresses knowledge gaps that are important to patients and to their families and clinicians. Thrombosis Ireland and INVITE also importantly partner with policymakers, decision makers in Ireland who can fund and change the way we deliver care. And we've jointly served on a number of Irish VTE committees. Anne-Marie and I have jointly delivered addresses at the EU Parliament, in Queen's University Belfast, University College Dublin, and with the Ireland East Hospital Group Chief Executive Officer. INVITE and Thrombosis Ireland also jointly published manuscripts raising awareness of the VTE patient experience for World Thrombosis Day, both in 2020 and recently in 2021. Patient partners are equal and active members of the network and are involved in setting research priorities, patient advocacy initiatives, and knowledge transfer activities, such as the VTE Dublin International Conference, which takes place annually, where you can see here Anne-Marie at the official launch in 2018 of INVITE. So INVITE works very, very proudly with Thrombosis Ireland, as you can see here, represented on our Executive Management Committee. And we work very closely with the Irish Health Services executives, so policymakers. We are based in the University College Dublin Clinical Research Centre and engage strongly with 4 university CRCs around Ireland in a hub and spoke model. And delighted to say we've recently appointed a full-time network manager. INVITE collaborate proudly and strongly with many other national networks under INVENT-VTE, and I've highlighted in particular CanVECTOR here and the Dutch Thrombosis Network because, as you'll hear, we've partnered particularly strongly with these national networks. I'm very proud to do so. Because INVITE is absolutely committed to conducting research that is meaningful to patients and their families, patient partners have from the very beginning been embedded in all aspects of network growth planning, including, of course, selection and prioritization of studies. You heard from Anne-Marie about the story of Niall, shared, of course, with his family's permission, which led to the theme of VTE after lower limb injury being prioritized early in INVITE's gestation. This culminated in the establishment of the Tillery Prospective Observational Study, or thrombosis in patients with lower limb injury. This study has already recruited over 1,000 patients through 9 Irish partner hospitals and a Brazilian partner site to open soon. It's been a privilege to be able to deliver on this patient prioritised research. VTE in pregnancy is also very important to invite patient partners and clinicians, and of course a subject close to my own heart. In Ireland and the UK, pulmonary embolism remains the most common cause of direct maternal death. An early patient-led priority for our network has been Irish participation in high-quality pregnancy VTE studies. Under Professor Saskia Middledorf's leadership, the academic, multinational, high-low randomized trial evaluating optimal VTE prevention in pregnancy has been completed, a remarkable achievement. We were proud to be involved. We are also soon to commence recruitment to the pilot PARDAM trial, led by CanVECTOR colleague Dr. Leslie Skeeth, who's tremendously inspirational, evaluating the feasibility of a large trial comparing aspirin with placebo in prevention of postpartum VTE. And we've also participated in the Artemis study, evaluating diagnosis of PE in pregnancy and published in the New England Journal of Medicine in 2019. We're also delighted to announce that INVENT recently won a prestigious seed funding award from INVENT-VTE to support the Women's Health Medea study. Again, a theme prioritised by engagement with patient partners. Anne-Marie, would you like to comment further on the importance to you of VTE research in pregnancy?
Oh, this is something that's really close to my heart as well, because having experienced 2 PE previous to finding myself pregnant, I was kind of, it was a crazy panic when I got pregnant, and it was, you know, so scary. And I had to inject every single day of the pregnancy, and I didn't know anybody else that had happened to. And then I found out after the fact, I was worried about the baby. I was worried sick about injecting anything into my tummy when I was pregnant, but you know, it was really stressed that I needed it to keep myself safe, and that the baby would be fine. But little did I know really that was best practice was being used to decide the level of medication that I was going to take during the pregnancy, that it hadn't been scientifically proven the exact amount. So I think I might have thought twice about actually taking it had I known really. So I think the more we will keep our girls safer, the more scientifically proven treatments that we have. So I want to, you know, thank Professor Saskia Middledorf and everybody who's done the work on this project. It's fantastic. Thank you.
Thank you, Anne-Marie. So what do the next 5 years hold? Well, during the coming 5 years, we anticipate the organisation of many more patient-clinician partner events, TV and radio media events, and further development of our patient-centred research portfolio. Like our CanVECTOR colleagues and patient partners have acted, we've been honoured to have served on grant applications as principal investigators and co-author publications with us as named authors, and all of these activities will continue and grow. INVITE commits to constantly strengthen our core PPI engagement programme through structured recruitment of new members, and we're delighted that we're always getting new members and attracting so much enthusiasm, talent and inspiration that really drives what we do. We will continue to be involved in development of key core outcome sets with patient-reported outcome measures. And Carol West mentioned the VT cost project, and our INVITE colleague, Dr. Crowley, we're very honoured to have her participate in that incredibly prestigious process. Research prioritisation workshops, and if funding permits, we also envisage becoming involved in a formal James Lind Alliance process. And of course, joint knowledge transfer activities, such as this one. Do you remember this, Anne-Marie?
This was a wonderful moment. It was actually the very first time that we had a research scientist, Professor Patricia McGuire, give a presentation on the work that she's doing on the tiny bubbles, the EVs, and it was just the reaction in the audience. This is our patient at our patient conference, our annual patient conference, to actually realize that there were actual scientists trying to research and get answers in this area. They were absolutely delighted and were, you know, really offering to help in any way possible. But it gave them hope. It gave them hope that people cared enough actually to really look into their condition and get answers. It was wonderful.
Thank you so much, Anne-Marie. I hope we've convinced you so far that partnership is mutually so beneficial. And of course, patients, clinicians and scientists need also to partner and to engage with policymakers and the public in order to make sure that our outcomes and our learnings are translated into policy and guideline changes. So I'm honoured again to hand over to Anne-Marie to talk a little bit about this journey in Ireland.
So we were starting at a pretty low base. I mean, nobody really was talking about blood clots. Nobody had any idea what VTE was, what Ps were. People had an idea maybe of DVT, just about long haul flights, but we were trying to get like a national message into people's homes, but particularly into any patients who are inpatients in hospital, because 60% of these blood clots happen as a direct result of a hospital stay. But as a patient, my real concern was those 90 days where you're still at risk when you go home. So if patients don't know about the risk or they don't know about the signs and symptoms, how are they supposed to protect themselves? So I really felt it was a responsibility of the hospital to make sure that every patient knew about their risk, possible risk, and knew how to protect themselves should it happen, and knew to act fast, because we know if you act fast, there's normally good outcomes. So our first attempt at really getting this message across was to develop our blood clot alert card. It's actually a small little card here that folds over and fits into a wallet. And it gives, you know, what you can do to help yourself, what your risk, what will increase your risk, and the signs and symptoms, and really expressed, you know, to act fast if you had any of these signs and symptoms. So our health department actually adopted the alert card and printed 1 million of them and distributed them around our, I think there's about 32 hospitals, acute hospitals around the country, and they were delivered with the view that they were going to be distributed to every patient before they were discharged from hospital, so they knew how to protect themselves. It worked in some, didn't work in others, but it's a work in progress. But it was our first attempt to basically make it a bit easier for doctors to quickly give that information and allow patients to have a read and come back and ask questions. And then from the alert card, then we were also doing like events in individual hospitals around the country. We have 7 hospital groups, and you know, they have anything from 7 to 12 hospitals in each group, but there was no connection in what we were doing, and we found that for the amount of work that we were doing, we weren't really having the best impact. So our first collaborative event really was our Big Red Bus, Stop the Clot, Big Red Stop the Clot bus, with Ireland East Hospital Group, with Professor Fionnuala and the communications group, and also the CEO of Ireland East Hospital Group, who have, I think, 12 hospitals. So over a 6-week period, we took that bus to each one of those hospitals and educated every person in those hospitals as best we could, from physios to dietitians to orthopedics to oncology, invited them all onto the bus to learn and listen to our simple message: know the signs, know the risks, and encourage your patients to act fast. And we found that there was really actually a surprise and knowledge gap from department to department, and people really did learn from the activities in each of those sites. But not only did we go to the hospital, but we took that bus into the community. So we might do the hospital in the morning, in the community in the afternoon. We pulled up on the main street or the market square or on the quays, whichever, and invited the community in. We also had national radio advertising on at the time, letting people know what we were and what we were about. So it was a fantastic success. I think we reached about 3.6 million people in that 6-week trip, and hopefully saved some lives in the process. Since then, we haven't been able to repeat the Big Red Bus in 2020 and again in 2021, and we just had to decide to go virtual. And we did, last year we did TV and national radio campaigns, and this year we went local radio. But the biggest reach really was on each of those 16 local or 15 local radio stations on World Thrombosis Day or the day before. We had patient and clinician interviews, a local hematologist or nurse specialist with a local patient all over Ireland, telling their story and explaining the signs and symptoms on local radio, and we have had massive feedback from that. Our latest the latest one is on the 11th of November, and we're in University College Dublin in collaboration with Science Foundation Ireland and the Conway Sphere Centre. We're having a coffee and cupcake event where we're reaching out to every department in the university: communications, physio, mathematicians, for statisticians, science, physical recovery with the physios, midwifery, nursing, every department, to come up with your ideas on research ideas for improving women's health in thrombosis, and everybody get a free cupcake and a coffee, and hopefully it'll work. So we'd be delighted to feedback any of the ideas on that afterwards. It's a very exciting project. Thank you.
And patient stories.
Oh yes. So also at our conference this year, and it's really important, and we got such good feedback from it. So VTE Dublin, as you know, is an international conference on VTE, and what we tried something slightly different this year, in that Thrombosis Ireland organised 5 patient stories on 5 different topics that were being discussed and researched during the conference. And to me, what it did was it kind of gave like a human element and an understanding of why we need you guys to research and do the best that you can within our hospitals, because the patients need you, and if you don't do it, nobody will. So we will work together and do whatever is necessary to help you guys. Thank you.
Wow, Anne-Marie. Well, look, with that, I hope we have convinced you that partnership between patients, clinicians, scientists, and policymakers and the public is a great ingredient list for hopefully advocating for better care, better health of our community from VT perspective. Thank you all so much for your attention, and delighted to take any questions that you have.
Thank you very much. That was really great as well. It's fantastic what you've been achieving, for sure. We have a few minutes for questions, so it's time to enter them into the chat. It strikes me, right, how maybe different approaches or different levels of intervention in the network activities, but certainly I'm sure great inspiration on both sides actually as to what else we can do and how we can better engage patients in our research enterprises. So yeah, I wonder even if we shouldn't get like a, almost a collection of all these activities and ideas and stuff, so that people can, and I'm sure both of you would be, or the 4 of you would be open to people contacting you directly to get any documents or any logistical aspects of how you've been doing and achieving all that. It's really good. Maybe, all right, yeah. So someone is commenting. Well, you can read on the chat. I think you have it, but yeah, would agree with that. So there were 2 questions so far. One of them is we didn't touch a lot on the relationship between patient partners and research coordinators. I don't know if someone has anything to offer on that or a comment. Maybe Lisa first or Carol.
Yeah, sure. So I think it is important that the patient partner is part of the team, and with the full team. So it's not a conversation with one person and then a separate meeting with the rest of the research team. It's the integration of the team. And so, I think it's the patient partners, the full research team, and maybe not every item on the agenda is going to be something where the patient's going to raise their hand and contribute, but some of them are, and you might be surprised at which ones they actually have a really important insight in. It's not always obvious, and so not worrying so much, oh, is this relevant for a patient? Will I invite them to this meeting? But just including them as part of the team and let the patients raise their hand as they need. The operations of day-to-day running a trial, patient partners tend to be more on the scientific steering committees and the oversight, but have given a lot of contributions into consent forms and promotional materials for trials. And I can tell you, I've learned personally so much from Carol and our other patient partners on how to effectively communicate information in a way that's understood and doesn't intimidate people off. So that's been one area.
Good. Any other comments for the other panelists on that question?
Yeah, thank you. It's you know, such a great example of how the entire team have to work together. Anne-Marie spoke about the important theme of thrombosis and lower limb injury, and you know, our artillery coordinator in University Hospital Limerick, and you know, Anne-Marie will have communicated so often during the gestation of this trial, and you know, coming up with ideas to increase, you know, patient participation, to increase recruitment. Again, what you said, Carol, about, or Lisa, about promotional materials, not so much that, but trying to come up with creative solutions to raise clinicians' awareness and to try to increase recruitment, particularly, you know, in busy emergency departments or fracture clinics. So I think the trial coordinator partnership with the patient is, I'm delighted that it was raised as an important and crucial central component of the process. Thank you.
Good. There was another question back to the patient compensation. And I think if I understand the question correctly, was, you know, where is the money coming from when you compensate patient partners? Is it from the hospital or some other sources?
You could go at that one again.
Yeah.
So for us, it comes from various sources. We do think it's very important to include patient partners really early in a project, and of course that's usually before there's funding for the project. And so we're very grateful that CanVECTOR has provided us an opportunity to compensate the patient partners' contributions that happen to projects even before there's a formal funding for the project. One of the advantages of actually having an outlined compensation policy, and there's some in Canada, at least some guidance. I know the UK also has some great resources to support and justify the compensation, which is important. So it's something that is included as a budget item and part of project grant applications. That's been very well received. In fact, I think you may actually strengthen your application by including that, because it shows that you're serious and committed to the patient engagement. And you know, and again, the focus is not so much on like a job or an hourly rate, even though we do calculate the compensation in a similar way, but it is an acknowledgement. It's an honorarium as a contribution of their contributions, which, you know, monetarily would be valued even higher, of course, but I think it's an important step nonetheless.
Thank you. Great. I guess we just have 2 minutes to wrap up. So maybe we can go to the last slide, Caleb. Yeah, and to thank you again all for thank the speakers first, obviously, for your great talks, and mostly for all the work you do to help patients and researchers alike in that journey on improving VTE research and getting the answers that we much need. And thank you also to our network sponsors that are listed here, and again to Sanofi for providing financial support for this particular webinar. So thank you very much again. Have a good morning, after rest of your afternoon or rest of your evening, to rephrase Carol, and see you all soon.